So we're going to talk about biologics for paediatricians. They're really important. I'll explain why. They're going to come up in the exam in the future, and they certainly come up in the exam in the past, haven't they? Why are they important? You know what? There are 23 biologics in development at this moment for asthma alone. So we're looking at the future. The future is biologic. I can tell you asthma because I'm an asthma researcher, so I kind of know. 23. Wow. They are at the moment expensive but highly effective. And when nothing else has worked, biologicals will. But they're almost impossible to learn about quickly. And a lot of it relates to what do the basic fundamentals of the pathology. So if it's an IL-10 mediated pathology, maybe an anti-IL-10 might work. In severe eosinophilic asthma, we know IL-5 is really important. So anti-IL-5 works. We'll come on to that. I'm going to give you some tricks of how to save learning all the individual things. Let's try and make it simple to make it easy. And some advice about how to think about different types of biologics. So what are biologics? Biologics are complex, large molecules. If you look at drugs, drugs are little. Drugs are simple. If you look at biologics, biologics are big, they're complicated. They're applicable to prevent, treat, cure disease in humans. But there's all sorts of things. They're not new. Let's think about biologics. We can have vaccines or immunotherapy. My goodness, we're going back to Jenner. Even Jenner was around even when I was in medical school. Okay? So vaccination, immunotherapy have been around. If we go to immunotherapy, we're talking about Coker and Cook. 1916. So 2016, 100 years since the birth of immunotherapy. We're talking about plasma-derived proteins. Cryoprecipitate, fresh frozen plasma. Hey, they're plasma-derived proteins. So we're not talking modern until we get to monoclonal antibodies. And they're not even that modern. They were around when I was in medical school. So they've been around for a long time. Fusion proteins. I love, that's my face, that's my, oh no face. I genuinely did it. I genuinely got to an exam. Has anyone seen the Mr. Bean when he's sitting a maths test exam? Have you felt like that in TAS? Have you felt like it? Well, he gets and he reads it, and he turns it over and it's blank on the back. And then he does this, he's trying to open the paper. I've been that candidate. That was me in my biochemistry exam as an undergraduate. And everyone else was writing. He does the looking around. Everyone else was writing, and I wasn't. And I just went, I am so toast. I have the record for the lowest mark ever in biochemistry to have passed the exam at the time when I did it at Oxford University. I got enough marks in my viva, because I'm good at talking, to bring me up to the pass mark, and the course secretary took me on one side and said, how did you pass? I said, it was quite easy to accrue more marks, Gwyneth, because the first question that I answered on the title of fatty acid cycle, I wrote, fat is the most important source of glucose in the human body. I don't think I could have constructed a more wrong sentence in biochemistry if I'd have tried. So there you go. Brilliant, eh? Other than writing my name at the top of the paper, it gave the external examiner such a laugh that he took pity on me in the viva and managed to get me through. I think it's a cruel joke to Oxford University, really, to set me through. I have learnt a little bit more biochemistry since then, it's safe to say. Recombinant human proteins. Don't worry if you don't know it in exams. Okay, poor performance in one exam does not mean poor performance for your whole life. It just means poor performance on that exam. I can remember freaking out, proper freaking out in that exam and just writing garbage. Okay, so I've been there. Where should you concentrate? I know where you don't get it right. Here are the answers. Omalizumab, live viral vaccine, etanercept. I know what you need to know. I knew before you came. Right, let's talk about vaccines. This is a nice list. This is an easy list. The first biologics were vaccines, and they were live vaccines. So let's talk. We had smallpox first of all. You want to know whether it's a live vaccine or a dead vaccine, because it's important to know that, because there are certain conditions where you don't give live vaccines. What are the conditions where you don't give live vaccines? Yeah. That's it. Immunosuppression. Anything else? HIV. Yeah, there's lots of conditions where you... Yeah. Anything that basically makes you at risk from that live attenuated vaccine. And possibly, if there's a better version of the vaccine that's not live attenuated, it isn't always the best answer. Nasal flu. American Academy of Paediatrics have said no to nasal flu. This year, that's hot off the press, 2016, sent out a statement about 3 weeks ago. We do not recommend nasal flu vaccine because only 3% protection was offered compared to 66% with IM. So live isn't always best and live isn't always safest. You also need a gap between live vaccinations, don't you? Okay, so things like yellow fever, live vaccine. Certain people can't have it. Things about live vaccines. Some of them, in fact a lot of them, made in egg. Okay, they're made in egg. At least they're grown in egg because they're live. So they may have egg in as well. Often it's not a problem. Inactivated vaccines. There you go. Polio. You can't give that because you're worried about the child's immunity. So you give that. Fair enough. No problem. You might give that to the sibling of a child with an immune suppression problem. Because if you give them oral polio, they're going to shed polio virus. Uh-oh. That might be a problem to the other child in the family. Got subunit vaccines. Okay? You know, only a bit. Can't reproduce. Can't cause the disease. Got the bits of immunological interest. Delivers protection against the wild type. Unlike toxoid vaccines. Don't stop you getting the disease, but stop you getting the illness. Tetanus toxin. So you generate antibodies to tetanus toxin, not to Clostridium tetani. If you know those little bits, you're going to be well prepared to answer the EMQ on vaccines, aren't you? How are we going to subdivide? We're going to have a list of 9, 10 vaccines. We're going to start telling you things about them. And we're probably going to be discriminating on is a live, is it inactive, is a sub, yeah? Do you see how you've got the list down straight away? There you go. And then that protects against, and then a condition associated with, and then add a little bit more information. We've seen this picture from Sally. I do little cartwheels of happiness when I see my faculty go off into areas that I know I'm going to touch upon again. See, good teaching allows you to interdigitate and speak about what the previous speakers have spoken about and what's going to come up going forward. I saw the slide yesterday, I did a little yay! So this 14-year-old girl who you saw the pictures of yesterday with hereditary angioedema presents to the emergency department with life-threatening airway compromise, which is most likely to result in a clinical resolution. Hard question. 20% of candidates will get this right by the power of guessing. So let's see how you do on this list. What do you think, guys? Don't shout it out, just try and do the question. And I want you to write and commit your answer to a piece of paper in front of you. So there can be no cheating whatsoever. so that everyone else can see, so that other people can see what you've done. You can write it on your post-it notes if you want, because we can stick them up in the air. Okay. You've all got to vote. So I'm going to do it in reverse order. Stick your post-its in the air if you've written E on them. Stick your post-its in the air if you've written D on them. Stick your post-its in the air if you've written C on them. Stick your post-its in the air if you've written B on them. Stick your post-its in the air if you've written A on them. And the answer is... We'll come to it. You're going to love the answer when you hear the answer. You're going to love the answer. When I turned up to Stoke-on-Trent, I was told... I was trying to get my charm to work on the nurses, because I'm a charming man, okay? And I was trying to get my charm to work on the nurses. And there was I, new registrar, wag, wag, wag. And you go... Nothing was working, you know? Nothing was working. I've been in that situation before because I've got an identical twin brother, and it's when I followed him around and he'd already upset everyone because he's a surgeon. But it wasn't this case. And I said, after about 3 or 4 months there, I spoke to one of my colleagues called Imma Blanco. Imma was Spanish. I said to Imma, Imma, what is it? I'm just getting nowhere with the nurses. Why am I just, not favoured son at the moment? I just don't seem to be getting any love. And she said, you see, Carlos, he left. And everybody loved Carlos. I said, yeah, but everybody loves me, Emma. I've been to play, everyone loves me. He said, no. Everybody loves Carlos. So I do think, I do think everybody loves Carlos. It goes through my mind at least once a week. Whenever I'm saying something to someone and I'm not winning on the charisma front, I think, I wish it was Carlos, because everybody loves Carlos. You're a victim to who's been there before you in your jobs as well, definitely. They were still in grief because Carlos had left, and I could not replace him. Right, question 2. Hard question. Go on, write down your post-it notes. I'll give you a chance to read it while I was telling a Carlos joke. I'm not going to move on until I see you write on your post-it notes. Okay, I can see you putting off writing on your post-it notes because I'm not daft. You have to commit to an answer. I promise I'll tell you the answer to this one before we move on. This audience are too young to remember Paul Daniels and say, you're going to like it, but not a lot. In terms of the answers. Okay, in reverse order. Who put E? Who put D? Who put C? Who put B? Who put A? Hard look, everybody. It's a hard question. Actually, what happens in immunotherapy is it results in, initially, because it's orally introduced, it's oral immunotherapy, it results in the formation of IgG antibodies. An IgG specific to grass pollen that interferes with IgE signalling, which results in eventually a reduction in specific IgE. What a nightmare.
Can you just say that again?
Yeah. If you eat it, you make IgG antibodies. If it goes in through your skin or your lungs, you make IgE antibodies. This is a basic piece of allergy atopy science. It's a thing of beauty. As immunotherapy is a biological, I thought I'd cover it in this lecture, but the paradigm for understanding was unpicked by Filigrin. What has genetics ever done for me? In my case, not a lot. I did my MD in genetics, and I think I picked all the wrong genes. But there you go. I wish I'd picked Filigrin. Filigrin is an exciting gene story from the first part of the 20th century. If you have a Filigrin gene defect, you're more likely to have what I've got on the back of my legs, ichthyosis vulgaris. That's like a mosaic pattern of skin, but you're also much more likely to have allergies. The reason, filaggrin is a barrier protein found in skin. If your barrier function is disrupted, allergens can penetrate through the skin and make you allergic, because allergens that penetrate transepidermally result in sensitization and subsequent allergy. Likewise, allergens that you breathe in, and they have to therefore be of respirable size, aeroallergens cause allergy. Hay fever, pollens, dust, high in calories, low in calories, dust. All breathed in, or land in the lungs, all cause allergy. But if you eat dust, high in calories, low in calories, you become desensitized. If you eat pollen, you become desensitized. If you introduce foods early with weaning, like peanut, you reduce the risk of becoming allergic. The LEAP study, Gideon Lack, New England Journal of Medicine, most important paediatric paper of 2015. How does it work? Well, if you read the New England Journal of Medicine paper on the LEAP study, and why would you not want to after that build-up, you'll see the IgG antibodies increasing. This question is very hard, but tests interdigitating pieces of knowledge that are extremely useful and very topical. Just adding it to Illustrated Textbook of Pediatrics. Just adding it now to the nutrition section about weaning, and about how it says there's no evidence that early weaning is harmful. I've actually changed it. There is evidence that weaning early with foods can reduce the risk of subsequent allergy. One line, and I've not explained it because it's an undergraduate textbook, but very important. You'll find it in Science Pediatrics. So understanding this is a huge piece of work. This one slide. We'll come to the cryo in a second, because I'm going to tell you about plasma-derived proteins. There's only one slide, you'll be pleased to know. You can get lots of things out of blood, and basically you spin it down and you do different processes. The things you can get out of blood are all useful, and the first process is to spin it down and get cryoprecipitate. Okay? That's the first precipitate you get out of blood, and it contains everything else, which you might understand also includes C1 esterase inhibitor. So of my list, although you've never used cryo before in your life, you now know what cryo is. Cryo is before you get to FFP, and it's got everything in it. And that would include C1 esterase inhibitor. So if you're up Pooh Creek and someone comes in with hereditary angioedema, and I was so desperate to shout out yesterday, give him some cryo, okay, because you can always get it. Okay, I was so desperate to shout, but I held myself back, didn't I? I held myself back. Okay, adrenaline isn't going to work. And I was thinking, but I know what is. And I know they don't know what is. Okay, so they come with C1 esterase inhibitor. You can sometimes find it in the fridge, but sometimes you can't. But you can always get some cryo, some blood products, some FFP. That'll work then if they've got a life-threatening problem. You might not be thanked for not using the C1 esterase because you've exposed them to risk. What risk have you exposed them to? Well, you've got pooled 6 units for 1 unit of cryo. So you've got 6 units of transfusion that you don't have to go and say, I've exposed you to the following risks. Those are estimated from the US. So give them the C1 esterase inhibitor if you've got it, but if you've not got it and they're going to die, I think the chance of death from any of these is smaller than 1 in 1, yeah? So if you're a bit of science will help you, yeah, in your clinical practice. So fortune favours the prepared mind. I had 1 patient with hereditary angioedema in Derby. I have met 1 patient in Stoke since I've been here. And I said, have you got your pen? And they said, yeah, I keep mine with me. They've got a cryo supply, so they bring it in with them when they're having hereditary angioedema. But I know that if they've forgotten it or they're on holiday, what to do if someone rings me at 3 in the morning as the consultant and says, oh, this patient, help! Get some cryo. Okay? That's what you say. So you need to be prepared for what to do in an emergency. That's all I'm going to say about blood products. But it was quite useful, wasn't it? Ah, yes. Well, this list of agents makes a very suitable EMQ, doesn't it? Let's start with the first piece of membership gold. If it ends in MAB, it's a monoclonal antibody. If it ends in sept, and a few other things, it's a fusion protein. So there was only one fusion protein, wasn't there, in the EMQ? Now you know which one it was. It was the one that didn't end in MAB, so that would have made it a bit simpler, wouldn't it? Let's talk. There's 3 respiratory monoclonals. You've come across them, so I'm going to ask about them. Stick your hand up if you've never heard of or given palivizumab. Okay, and I can say it out loud, Synergis. Palivizumab. I've obviously been to a lot of Abbott-funded events over the years. Okay, I don't even know if they make it, actually. I don't think I have, actually, just for the record. Okay, omalizumab. Stick your hand up if you've seen or given that. Okay, it's very, very important. It's nice. It's for severe asthma. So treatment, it's a really good treatment. I think we have about half a dozen in Stoke. We had 3 in Derby. So you will come across it and use it. It's anti-IgE monoclonal antibody. It's got a whole load of uses. It works in treatment-resistant chronic spontaneous urticaria, previously known as chronic idiopathic urticaria, which is a very debilitating and difficult condition if you keep on coming. In fact, looking around the room, we've got a little X chromosome bias here, haven't we? So who here gets idiopathic urticaria, so gets lumps from time to time? Yeah? If you had that resistant coming along all the time, it's very unpleasant. Omalizumab works. That paper was in the New England Journal of Medicine. That is NICE funded. It's NICE approved. So even though it's expensive, it's NICE approved for treatment resistant. If you're on your antihistamines, it's not getting better, funded for that. So it's a good thing to know about. There's lots of New England Journal of Medicine papers on omalizumab. It's established. Main use is going to be asthma. NICE funded in asthma. Also NICE funded even in children in chronic spontaneous urticaria, previously known as chronic idiopathic urticaria. Probably also works in severe treatment resistant eczema, but not NICE funded. And then, sorry? Oh, no, chronic severe. So you don't use it acutely. Although, interestingly, just for fun and giggles, IgE goes up in an acute asthma attack. It is raised. No one knows why. So, we don't use it acutely, but maybe we should. Anti-IL-5, MEPO. Okay, it's a new kid on the block. This was New England Journal of Medicine, 2015. Tell you a story about this paper. I gave a lecture at the ERS about FeNO, about exhaled nitric oxide, in 2015. And I was doing the session. Mike Thomas is a professor, everyone else is a professor who's giving a talk, but Mike Thomas is a professor at Southampton. Mike stood up and gave a lecture. He said, I'm very pleased to announce that we've got 3 panel members here and myself, and between us we have 3 papers in the New England Journal of Medicine this week. Unfortunately for Will, 2 of them happen to belong to Helgo and 1 belongs to Ian, which was a joke at my expense. But I gave a talk with Ian Ford about FeNO and Helgo Magnuson, who had 2 in on COPD. So I can remember this paper being delivered because I saw Ian present the original slides. This is very important. It was work done in adults. They get all the nice toys first. This is coming in kids. There's a MEPO study going on at the moment. Placebo. This is your Kaplan-Meier upside down, isn't it? You've got placebo. You get asthma exacerbations. We've got exacerbations going up here. Very effective at 75 intravenously or 100 milligrams subcutaneously. Very good at reducing asthma exacerbations. If they had severe eosinophilic asthma, this group had high FeNO, of course, because those 2 things go together. Let's keep it simple. gastroenterology monoclonals. There are 3. Infliximab. It's the one that's been around for longest. Nice, recommended. Severe active Crohn's. Severe active Crohn's is very poor general health and weight loss or fever, severe abdominal pain, 3 or 4 times a day, stools, 1 or more of. That's actually quite a lot of people with Crohn's when we look through our hospital practice. We try conventional therapy first, but if they're not responded, they get on infliximab. It's really good for fistulating rectal disease, but it has risks associated with it. Put someone on infliximab, what does it do? It's an anti-TNF agent. Okay? All of these were anti-TNF, by the way. Sorry, I just should go back. They're all anti-TNF, yeah? So anti-TNF. What does it do? You get short-term reactions. It's very common to get itch, flush, and chest discomfort. That's responding to something in the infusion. It's not an allergic reaction. And that treatment is commoner in treatment-naive children, which kind of says it's not allergic, is it? It's better with time. You can get anaphylaxis. In fact, you can get anaphylaxis with all the monoclonals. And it's not immediate. It's often, it can be within the first 24 hours, unfortunately. So that's a bit of a burden. So you give them the omalizumab, send them home, and then they can have a reaction at any point in that next day. We don't keep them because it's rare. Medium term, they can get immune complex. Anyone seen the words immune complex come up in the context of a hypersensitivity reaction? Oh, yeah. We thought we could forget that slide, didn't we? Okay. They get immune complex deposition. So that might be an important hypersensitivity reaction to revise. TNF has important immune effects. This means once every 30 years, you get a serious infection. That could kill you. Okay, that's significant. So it's not just all good going on to a biological if you've got inflammatory bowel disease. Almost 1 in 12 gets either eczema or worsening psoriasis. And that's so common as to make a really nice question, isn't it? What are the side effects of? What are the common side effects of? You screen anyone starting on anti-TNFs for TB, HIV, and hepatitis B before you put them on it. Because turning off that TNF can cause them big problems. And you don't give them, hey, we've got another reason for not giving live vaccines now, haven't we? You knew it was going to interdigitate, didn't you? You knew it was all going to fit together somehow. There are long-term risks, potentially, of malignancy. No one's really sure. So let's just go through the different types of where do they work. And I'm going to do that by talking about rheumatology. Now, gastroenterology and respiratory are pretty straightforward. But rheumatology, I've got a list, as long as your arm, of monoclonals and biologics. And they use them for everything. And they're all far too complicated. And they're really, really expensive. But let's just whiz through a few of the more important ones. Found in the book. Okay, guys, found in the book. Etanercept. How does it work? It's a TNF-alpha soluble receptor. Is it a monoclonal antibody? No. Well done, everybody. That's right. No, it's not. It's a fusion protein. We give it subcutaneously. Infliximab. Human mouse chimeric antibody. So it's a bit old-fashioned. It's human mouse, but it's been around for a while, therefore, neutralizes TNF. Is it a monoclonal antibody? Yes. Yes, exactly. It's easy, isn't it? You know it's... Right, okay. How do we give it? We give that by an infusion. Have to be in hospital usually to have it, therefore. Adalimumab. Monoclonal antibody. Yeah, enzimab. It's the fully human form of infliximab. It's kind of newer. Advantage being you can give it by subcutaneous injection, and slightly longer between dosing regimes. Right. Oh, I love this next one. So, what do you reckon? Canakinumab. Monoclonal antibody?
Yes.
Rilonacept? No. Anakinra? No. Okay, I think it's no. I'm not absolutely certain, but I think it's going to be no because it'll end in mab if it's a monoclonal antibody. Okay, I think it's fusion protein as well. Can't remember. But you know what these three work on because we wouldn't probably just give you the name. What does IL-1 cause? You all know this. I feel a bit more sun coming on. Fever, you gave me fever, fever all through the night. Fever! Oh yeah, okay, so IL-1 causes fever, doesn't it? So what are these things used for? Periodic fever syndromes. Oh, you never thought we'd get onto them, did you? Oh, love periodic fever syndromes. Happily, not too much of it in task for you guys. Okay. But they're there, they're on the list, okay. Rituximab. Okay, rituximab, bit clever. Rituximab against CD20. CD20 is found just on B cells, mops up your B cells. Do you remember Steve this morning? CD34 positive, CD20 negatives for stem cells? Yeah? Yeah. Okay, good. You don't really need to know that level of detail. Hardly like to come with the exam. It's just kind of nice to know. It's kind of nice to know. How do you work out what's a progenitor stem cell? Well, you kind of look at the CD molecules. Are they of any value? Yes, they are. Because if you want to just wipe out your B cells, just go for CD20. Make a monoclonal antibody. That's why it's worth knowing this. If you're a scientist, why would you want to wipe out B cells? If you've got an antibody-produced autoimmune condition, yeah? Then getting rid of your B cells is probably a good idea. Don't need to get rid of your T cells, get rid of your B cells, okay? Tocilizumab, IL-6, no idea what you use it for. It's in the book. So, you know? Yeah, it's probably a JA. I mean, it's rheumatology, isn't it? Something. No, I personally don't know. I suspect it's on the list of JA. But you wouldn't be able to discriminate that on an EMQ, I don't think. I think it would be a bit harsh. Say, because a lot of these will treat JA, yeah? A lot of them will be useful because they dampen down the immune response. Abatacept. Never used it. Sounds a bit, rheumatological to me. Probably JA as well. Yeah. Who knows? There's some general advice. No live vaccines. Annual flu immunisation. 5-yearly pneumococcal. Don't get ill. Be vigilant for infection. And advice about what to do when they're travelling, about where to go and when to seek help. Along with information. Immunosuppress people on these medicines. And you're more likely to be asked the generic advice and basic things. Like the following is a monoclonal antibody. And you'll look at it and you'll go, I know the answer to this because it's the only one that ends in mab, or it's the only one that doesn't end in mab, yeah? And you go, I know how I can answer this question. This question is ridiculously hard, except, wait a sec, mab, sept. Yeah? And you go, how did the examiner expect to know this? Really fine. I didn't even bother reading the question because I just freaked out when it said in the treatment of juvenile idiopathic arthritis. And I went, I knew I should have read that chapter. Read the question. Use the tricks and tips. They'll really help. If nothing else, they'll get the list a bit shorter. Rheumatology uses the rare ones. If I was asked if someone was saying it's a monoclonal you never heard of before, or a fusion protein you haven't got a Scooby, and it wasn't on the respiratory and gastro list, it's likely to be JIA. Yeah? Because the rheumatologists use the rare stuff. Right, final phase of biologics. You're almost there, guys. I'm slightly worried that Dr. Gilchrist doesn't appear to be here yet, but there you go. Anyway, he has rung me already twice today. Hopefully he's not trying to ring me right now. There are 4 main groups of recombinant human proteins that we use. And it's going to be a good day where you get this in the exam and you know the answer. There's a combination of things here. One is, it's not that likely to come up, but if it does, and you know the answer, then it's gold. Remember, you're in the 3% who got my cryoprecipitate question right. Yeah? It's rare to know that question. So you're in the, you're much better than 20%. You will find that that actually 20% means that quite a lot of the candidates know the answer, 20%. Because when it's really hard, like the cryo question, no one gets it because they all go for adrenaline and antihistamines because they seem to make more sense. This one will be a very small proportion of people who get them right. There's some very specific ones. We talked about clotting yesterday. Factor 8. Okay, factor 8. It's a biologic. What else would we use? EPO. It's biologic. Interferon beta. Maybe in MS, early onset, yeah? It's biologic. With a few rare treatments for mucopolysaccharidoses. If you're doing these and you're getting these right, well done. It's not going to make the difference between you passing and failing. Not compared to everything else I've been teaching you, okay? If you know it, good. If you don't sweat it. Because metabolic is hard. Here is the impossible list. Okay? Don't freak out if you don't know this list. Here is the impossible list. Metabolic is hard. This is for guys who've done everything else, and everything else is nailed. You want to really nail the exam and be in that weird peak that I showed you at the beginning, yeah? The little step at the end. These are the guys know this. So people will know this who come and do the exam, but they're weird. Okay? They are strange people. Okay? They are definitely odd. They are the Patrick Davies, stroke Will Carrolls, stroke Ben Davies of this world. Okay? We're not normal, we're strange. Okay? But we know it. Okay? MPS 1, Laronidase. That's what I know because I've looked after people. Not going to save you if you've got hurlers, but might be useful if you've got hunters. MPS 2, idursulfase, quite a useful treatment. Bottom line is, if you've got severe type 1, if you've got hurlers, you need a bone marrow. And you need to get the diagnosis within 6 months. Fabry's disease, you're going to miss. If you ever make the diagnosis, great, there's a treatment. You'll save a life. We don't believe in asking questions, though, if it just tests list learning. So whilst there may be something in this question, if you read it carefully, it's very likely to be pulling up another principle that will allow you to answer the question. Yeah, of course you can. So hurlers, it won't come up. I mean, as far as I know, it's not there in the questions. But if it was, and it said, "What is the best treatment for Hurler's disease?" the answer is bone marrow transplant. Because that replaces all the enzymes. Yeah, that works really well. Well, it kind of works. Okay, it works. I don't know about works really well, but it works. My summary, in the hope that that was Dr. Gilchrist coming through the door, is that biologics are not just new. Okay, they've been around forever. Even before Dr. Carroll started practicing, they were around. There are 4 main groups, and TAS is aiming to test principles rather than rewarding rote learning. So don't rote learn. Learn the principles first. Then if you want to add to the principles by knowing a bit more, do a bit of rote learning, sure, but learn the principles. And don't panic. If they come up on the exam, cut down the list, first of all. Use your brain, try and work out why the examiner is asking the question. And then, remember, the exam should be using generic names, so it will be the kind of adalimumabs, not whatever adalimumab happens to be called these days. So it won't be palivizumab. So it won't be Synagis, it will be palivizumab. Yeah? Got it? Won't be Octoplex, it'll be factor 8. Yeah? Shouldn't be anyway. Might be, but that'll be a mistake on our part. But if you're bright enough to know that we've made a mistake, you're probably going to pass the exam. Okay, that's the other thing to know. If you can start spotting mistakes in the exam questions, you almost certainly have passed the exam. So if you're starting to think, oh yeah, he's made a mistake, you go, oh yeah, well, you're probably going to pass by that stage.